Off.
Well, thank you, everyone. So let's start. Welcome to our this next meeting. Thank you for everyone being here. I'm in a hotel because I'm in Washington, D.C., so apologize for my background. Let's start with reviewing the agenda for today. Today's agenda will be our welcome, reviewing our meeting notes, results of our vice chair and industry advisory committee update. Then we'll go into creating a shared vision for affordability, which will be all of that with all of us. We'll have a break and then come up with criteria for developing policy recommendations, and then we'll move into public comment. So anyone have any comments or questions on the agenda, or anything they'd like to add or change, or we need to address differently? Okay. Well, if something comes up in the meanwhile, please let me know. Please let us know. So then next, we will go and we'll review the September 15th meeting notes. And did everyone get a chance, let's see, to review and look at that? And I guess we have our results of our vice chair vote too. So did everyone get the meeting notes to look at?
Yep.
Good. Are there any edits or changes, or is there anything missing from the notes?
Didn't see anything.
Good. Does anyone, do we need to officially approve the notes okay, so if everyone's good, hearing no objection, we'll just accept the notes as noted. And then we have our vice chair email vote results. And Sarah, do you want to note that?
Yes, so we heard from all committee members. Our two nominated candidates were Stefan and Laura, sorry, and majority vote on this, and the vice chair is Laura. Congratulations, Laura.
Congratulations, Laura. And thank you, Stefan. Thank you, everyone, for putting your name forward and being part of the process. So thank you. Thank you. And then we'll have an update on the Industry Advisory Committee update. And Sarah, do you want to provide that too?
I can also do that. So the Industry Advisory Committee, the second body in this two-body structure, held its kickoff meeting on October 6th. The agenda was very similar to the Affordability Committee kickoff agenda. So we did a lot of introduction to the work, the charge, hearing why people were excited about the work. We had the group also nominated and selected a chair and a vice chair. So Eve Gray from Lane County will be the chair, and Alyssa Pirakanik from the Bend Anesthesiology Group will be the vice chair. And the group indicated some early interest in having a conversation about what success looks like. And when we're talking about improving affordability, what are the metrics? And so they're very interested in the conversation that you all will be having on today's agenda, because you are also interested in that. So some early alignment and iteration between the two groups on that conversation about when we say affordability, what do we mean and how will we know that we're making progress towards it?
Sarah, do we have a list of individuals who are part of that committee, or the groups that are part of that committee?
Yes, we can drop the roster in the chat momentarily.
Thank you very much. I appreciate that. Okay. Anyone have any questions or comments related to this first part of our setup and welcome? Okay.
Jennifer,
So,
can I just, sorry, technical note, you're really faint for me. I don't know if that's
okay.
true for other people, but if you could be slightly louder, that would be fantastic.
Okay, I'll get closer to my chair. How's that?
Thank you. That's better.
No problem. Or else I need to go find my headphones, but we're good. So next we'll go into creating a shared vision for affordability. We'll have a presentation from the OHA staff. The presentation is different ways to think about healthcare affordability, and then a decision discussion for us to adopt working definitions of affordability. And thank you for the material that you sent out ahead of time. Okay. And then Sarah, will you or one of the staff be,
Yes. Do you want me to start here? Okay.
yeah,
All right. So why are we talking about this today? So in the September kickoff meeting, there were a number of questions that came up. What is affordability? Affordability for whom? Are we talking about patients, providers, payers, purchasers? Which markets are we talking about? How can we monitor progress towards improving affordability? And then what lenses should the committee use when considering potential policies and strategies? So we want to frame up the discussion for you. We're going to present briefly on various ways that other states are thinking about this and give you a little bit of a framework for this conversation, and then leave it for your discussion, for reactions to that, and then potentially adopt a working definition for the committee. So the content in these slides that I'm about to walk through is pulled primarily from that Milbank blog post that we suggested as pre-reading about how states define affordability. So if you've looked at that, this is going to be a quick refresher. And if not, don't worry, we will provide the background information anyway. So next slide. We want to develop a working definition of affordability for Oregon, and for the purpose of this group, we want to understand what other states have adopted and where there's maybe some consensus or where there's some alignment across states, understand options for monitoring progress, and then this will inform the second conversation for today, the criteria for developing policy recommendations. So first, we're going to figure out what we mean when we say affordability, and then we'll know when we're vetting or considering policies whether or not they're moving the dial to getting there. So next slide. Let's start at a high level and talk about affordability for whom. So these 5 buckets give a couple of different ways to think about affordability. So for consumers and households, we might be thinking about, can we afford to access healthcare? This might mean paying out-of-pocket costs. It might mean being able to make appointments or fill prescriptions without delay or skipping. So if it might include being able to afford insurance premiums, as well as out-of-pocket costs. So there's a lot in the consumer bucket, and it all really comes down to, can we get the care that we need and can we afford the care that we need? For employers and purchasers, a key question is, can we afford to offer healthcare to our employees? For employers, this might mean the health plan premium increases don't cut into their margins or reduce their ability to offer competitive wages. Overall impact on the economy, whether or not employers can be competitive, whether or not purchasers are having to make hard choices about benefits that they're offering to their employees. On the state lens, usually this starts at a really high level. Can we balance the state budget? Can we afford to provide services to people? What are those services? How many people? And what are we prioritizing in the budget? This might mean managing Medicaid and state employee health plan spending. We can also think about healthcare providers and health plans and insurers. So on the provider side, can we afford to deliver healthcare? There were some comments about this in our kickoff meeting. The industry committee also had some reflections on this. This is things like, can we afford to have a robust workforce that is providing the care? Can we afford increasing supply chain costs to have a functioning facility? And on the health plan and insurer side, can we afford to cover care? So are we taking in enough in premiums or revenue to then be able to pay the claims and the services for the covered members? What does that benefit package look like? And how do all of these intersect with each other? So this is a really, really high level look at different ways to approach this. That said, next slide. The policy board would like the committee to focus on the 3 buckets on the left: consumers and households, employers and purchasers, and the state. This really is in line with your charter as a committee to amplify the voice of patients, consumers, and purchasers in healthcare policy decisions, and ideally leading to real-world changes for patients and consumers to access the care they need and ensure that access, quality, and equity are not compromised. This also fits in with the charge in the charter to ensure that the voice of those who pay for healthcare, patients, consumers, purchasers, and including the state as a purchaser in that lens, play a role in health policy related to affordability. This also aligns with most other states. When most other states are or have adopted a definition of affordability or some measures of affordability, they've really focused on the consumer and household lens at a single point in time, and then the state level. So state level healthcare cost growth and related metrics. are some of the primary indicators. And I'm going to pause there and ask Bill Kramer as our board liaison if he wants to add anything before we move on.
Thanks very much, Sarah. And thanks, Jennifer, for being the chair of this committee, and appreciate all of you being here today. This is very important work, and it's challenging work. What the board has tried to do is provide some just general guidelines in terms of what we think would be the best use of your time so that it can inform the work of the Oregon Health Policy Board and state policy generally. The there are issues, no question about it, that the healthcare industry, the hospitals, physicians, health plans all face in delivering affordable care. Their input costs, labor costs, and so on, are going up quite a bit, and it's a challenge to manage that as well as, of course, to maintain quality, equity, and access to care. But we think that for the purposes of this work, the crisis that we're facing is the cost to patients and consumers and employers and the state as a purchaser as well. So this is where we think the most needs to be done right now. And we would really appreciate your work in trying to figure out some both meaningful as well as kind of systemic approaches to trying to bring down the costs to consumers, purchasers, and the state.
Thanks, Bill. So with that framing and that narrowing, I'm going to walk through several measures, potential measures and definitions of affordability, and show some examples of how they're used in other states that align with these three buckets. So next slide. Let's start with the consumer and household measures. So these tend to be measures of whether or not individuals and families can manage premiums, deductibles, co-payments, and out-of-pocket costs, whether people are delaying or skipping necessary care due to cost, the household's total spending on health care as a share of income, and other self-reported difficulties in affording care. So let's look at some examples. Next slide. Starting with the percent of people who skipped or delayed care due to cost reasons. So this is a self-reported survey measure. We have several different options and data sources for this. Oregon relies heavily on the Oregon Health Insurance Survey, or OHIS, but for state level and more granular data. But there's also data from consumer surveys and Commonwealth Fund or other third-party surveys. This is a measure that Minnesota is using as one of their starting definitions of affordability. It really focuses on the impact, and it focuses on the delayed, on the outcome, that the care is being delayed due to cost. You can see an example on the graph of in 2024, the percent of Oregon adults who reported delaying healthcare due to cost was about 14.5%. That varies by what type of care. There's plenty of additional breakdowns. And we do have an online dashboard that sort of goes into depth on this measure in particular. So there's a lot to explore. Next. The second measure or definition here is the percent of households with unaffordable healthcare. This is the approach that Connecticut has adopted. They have a tool that they call the Connecticut Healthcare Affordability Index, or CHI, and it is a tool that labels households as having unaffordable healthcare if their expected spending exceeds 6.8% to 10.8% of income. So that also, scales depends on household size, what type of insurance, age, health risk, and geography. So there are a lot of breakdowns in the CHI tool as well. But you can see in the graph, all households in Connecticut, that first purple bar, 20% in 2019 had healthcare expenses exceeding the household income threshold of that 6.8 to 10.8%. Next slide. Vermont uses a really similar measure in their Green Mountain Care Board as they're reviewing health plans. And so they consider health plans to be unaffordable if the percent of household income spent on healthcare exceeds a certain threshold. So for employee-only premiums, that's 9%. with some specific limitations on cost sharing. So how much does the employee pay out of pocket in copays, deductibles, or other mechanisms? We have similar data for Oregon. We can pull it from a federal survey, the MEPS survey, Medical Expenditure Panel survey. I think I said that right. And so we can calculate the percent of median household income that people in Oregon with employer-sponsored health insurance pay for their plans. So the green bars on the left of this little chart show premium, deductible, and then premium plus deductible combined for people with family plans. And the blue bars show the same for people with a single plan. And combined on the family side, we're just under 10%, 9%, and then quite a bit less on the single plan, 3.6% in 2023. All right, and one more measure in this bucket, next slide. The Massachusetts Health Policy Commission has developed a measure where they look at the percent of compensation that is devoted to healthcare. So they classify families to face a high burden if the total healthcare spending, which includes premiums, out-of-pocket spending, and over-the-counter costs, is over 25% of their total compensation. That's a high threshold. Note that that 25% also includes the portion of the premium that the employer pays, not just the employee share of the premium. And they report on this in a dashboard as well, and the graphic just shows where Massachusetts is doing on that. Any questions, reflections on any of these consumer and household focused definitions?
And raise your hand if you guys have anything. I know offhand, when I look at these numbers, to me, all of them are way too high. And when I think about affordability, I would love to see it through the lens of keeping people healthy as opposed to the profiteering from illness, which to me changes the lens and changes the structure, because we don't have a health care system. We have a illness care system. And so that's why we have such expensive healthcare. And I just don't know, when I look at how much money we're spending on healthcare in the United States, we spend too much based on all the other things we have to spend. So to me, I can't even imagine spending 25% of my money as a high burden. That just seems, oh, that's hard. Kim.
Yeah, I have a question and a comment. So about 5 or so slides ago, you had an Oregon slide for results from a survey from Oregon. And I was wondering, maybe this is kind of too big of a question to answer quickly, but how are we doing versus other states? Like, are these numbers good comparatively or terrible?
That is a great question. I don't want to answer and give you the wrong information. I do know that there are comparable surveys as well as a cross-state survey like the Commonwealth Fund, and can share some more links if you want to look at that for a comparison. I don't want to answer off the cuff because I haven't looked at it lately, but has anyone else looked at a more cross-state comparison and wants to chime in on that question?
Note I would add, this is not from the Commonwealth surveys, this is from KFF's, KFF now is what they call themselves, survey. So which I'm trying to remember, I was looking at it earlier today, I think it was from July maybe of this year. And approximately half of folks, or nearly half of folks, of adults in the United States say that they struggle to afford their health care. And they go into specifically the delayed and skipped, but I don't know those numbers right off the top of my head.
Thank you. Okay, or maybe you can send some links later. That'd be interesting.
Sorry, I'm going to jump back in. Kelsey, is this the July KFF data? It looks like about a third of adults nationally.
Yes. Yeah. That makes sense. So a third skipped and delayed, and then half just say they struggle to afford, which I think is probably, I guess I don't know what the total, Annie, 14%. I can't do that in a fraction off the top of my head, but something there.
And I had just one comment on the accessing care. So it just made me think about the cost of healthcare for our employees. We pay for a portion of employee, but not the whole family. So if you add your family on, you are paying $19,000 a year just to have the privilege of saying you have health insurance. It's not for any care, right? So how do we, I guess, how do we account for the fact that healthcare costs so much, but it costs so much to buy it that then you don't have enough money to use it? And so the difference between getting healthcare versus actually getting to use it after you've paid $19,000 just to have it. That's all.
Very true, very true. Sorry, my name, I'm blanking on, I just see Priest as your last name, but
It's Patrick
Patrick,
Priest.
thank you so much. I'm gonna put that.
That's okay. Yeah. Oh, I need to change my thing. It just says P Priest. So sorry about that. I'll update that. I had a question, maybe a different one, and it's a lot of these metrics, they're very sobering, and it speaks to the importance of the work. I was thinking it's all based on income. And I just wondered about the proportion of those that are part of the system that are on Medicaid or Medicare that maybe income isn't part of it. And aren't we thinking about affordability for them too? I guess that's in the bucket of the state meeting its needs. And um, just, I don't know, as if we're picking a metric, I think something that includes the whole system would be something I would encourage.
Yeah,
Comment.
Patrick, I think we will talk about some more of those in the state bucket in a few minutes. But I will plug that the Oregon Health Insurance Survey, any questions that come out of that survey can be filtered by type of insurance. And so it's actually really interesting every year to see the percent of people who are on Medicaid in Oregon who do report that they're experiencing cost challenges because they shouldn't have a premium, they shouldn't have a copay, they shouldn't have a deductible for their services, at least the covered services. So that could be a reflection of they're trying to access services that they're paying for over the counter or non-covered services that they're still experiencing as a cost burden. It could also reflect confusion. So it's always interesting to see because that's a non-zero number every year.
Yeah, thank you. I changed my name too. Sorry about that, Jennifer. I should have
That's
noticed.
okay. That's okay. So I guess when reflecting on the definitions that were provided, and the definition that we need to come up to, in my own head, what is the long-term impact of the definition that we come up with today? Like, where will that be as we're looking at that?
And Jennifer, I think that's actually would it be okay if I ran through the other two
Yes,
buckets and then
absolutely.
come back? Because I think, again, the state bucket is going to
Yeah,
inform some
absolutely.
of that answer. And also, sorry, Linda, I saw your hand briefly. Did you want to jump in on this one?
No, I'll wait.
Okay. Okay, so let me go real quick through employers and purchasers. Next slide, please. Okay, so here we can look at the percent of the premium that the employer is paying. We can look at healthcare coverage versus wage growth. We can look at high deductible health plans, and we can look at the generosity of benefit. Maybe. It's a maybe we can look at that. Okay, next slide. So employer share of premium, again, this comes from that MEPS federal survey data. We have a lot of data on this for Oregon. We can sort it in lots of ways, but essentially we're looking at two different things. So the graph on the left of the slide is the percent of private sector employees enrolled in commercial health plans in Oregon that don't require any contribution. So the employer pays everything. You can see it's about 17% of people with a family plan and 24% with a single plan. The employer covers 100% of the cost. If we look at the right, these two graphs that are stacked up for the employers that don't pay 100%, what portion are they paying compared to what the employee has to pay? And we've stratified here by the size of the employer. So the larger employers tend to cover more of the cost. And we can look at this in dollars, we can look at this in percents. We have a lot of different ways to filter this. Next. Again, still coming from the same survey, we can look at the percent of Oregon employees that are enrolled in a high deductible health plan. So high deductible health plans are defined by the IRS, and they're a health plan with a minimum annual deductible that meets a certain dollar amount. That dollar amount is updated every year. So in 2025, a high deductible health plan was one where the deductible was $1,650 for a single plan and $3,300 for a family plan. In 2026, this is increasing to $1,700 for single coverage and $3,400 for family coverage. And about half of Oregon employees are enrolled in a high deductible health plan. So that's half of Oregon employees with commercial health insurance are in a high deductible health plan. And okay, next slide. So this is an example and a measure that Massachusetts has developed. I think it's really interesting. I don't know, I wouldn't promise how we would construct this for Oregon, but it might be worth exploring. And so what they're looking at is health insurance versus take-home pay. And they've actually developed a model where they say, all right, if an employer is going to grant a certain percent wage, how much of that wage would employees actually take home after taxes? And how much of it has to go to the increase in health insurance premiums and health insurance costs? And so they're able to separate out how much of that raise or proposed raises, healthcare, health insurance is taking up. So just another way to look at this and to do some projections. Okay, and then last, on the state side, state questions tend to look at this on a more long-term trend over time basis rather than a point in time. And their question tends to be, is overall healthcare spending growth outpacing key economic benchmarks? So is healthcare spending growing faster than the state's economy, than inflation, than wage growth, than income growth? And there are a variety of ways to measure that. And we actually have a whole separate work group right now that's running through our cost growth target program that's reviewing these economic indicators. And so if that's something that people are interested in, we can share the links to all those materials because we've just been rounding up all the data for this other work group. The second measure most commonly used at the state level that states are using for state level measurement is, can the state afford to provide healthcare coverage? So this is Medicaid, public employees, other services that the state provides, which vary by state. And then how many people can be covered, what the generosity of the benefit is, and what that means for things like reimbursement rates. So this is a very hot topic right now with HR 1 and all of the related conversations from that. And there are a number of ways to unpack that as well, which I think Jennifer gets to your, like, maybe tease up your question again if you want to start there.
No, absolutely. Well, and I was just thinking there was I was in a presentation, I heard a presentation last week that touched on overall economic trends in the United States. And it talked about a UCLA social determinants of health model, actually, and that 20% of our health is from healthcare. And so if we think about it from that perspective, if healthcare only impacts our health 20%, and the other 80% of our health comes from things not in healthcare, is that a place where we say, that's where the affordability lies, right? Because 80% of stuff outside of healthcare is impacting our health, and 20%, and is that maybe in alignment also too, that says, healthcare, if healthcare impacts our health 20%, then that should be in alignment from a number perspective. And then we figure out how to get to that with a cost and expense perspective, because people do have all those other things, those social drivers in their lives that impact health. And everything's getting more expensive too. So I was just like, lots of stuff to think about this week, but I was really kind of taken back a little bit about the healthcare only really impacting 20% of our health.
Are there any other questions or comments about any of the potential measures that we shared, or should I hand it back to you for discussion?
Linda.
Yeah, you had mentioned this about there's the self-reported types of things where somebody will say, I skipped care because I couldn't afford it. And sometimes there's some surprising things in that, especially related to Medicaid recipients who maybe don't have any cost sharing, but are still saying that they had to skip care. So I worry a little bit about using those self-reported, those types of surveys, because depending on how you ask the question and when you ask the question, you can get a lot of noise, I think, in the responses.
Yeah, Linda, I think that's a great point. And I'd also like to maybe add one more counterpoint in favor of some of the self-reported surveys, because I think it's also very easy to just look at the cost. Okay, this was your premium, this was your copay. But there are other costs that might actually, someone couldn't afford that result in delaying or skipping care. So I couldn't afford childcare or transportation to get to my medical appointment. That's not going to be reflected in the copay for the appointment, but it is in fact a cost burden. So acknowledging that this is like both of those things are true and scope creep for the group.
Absolutely. Stefan and then Laura.
Yeah, I just one comment about the some sort of payment for employers and employees. So I think like the overall payment, I think is very sensible to me. Shows the overall cost burden that's shared by those two. Um, I want to caution a little bit about looking at the percent or like the amount that employees pay. There's some sort of like some sort of like a basic economic principle that it's like what you nominally pay does not necessarily reflect what you actually pay, because the employer can adjust like wages or other parameters. So, for instance, like they might say something like, "Oh, we're covering all of your benefits, but then like your wages are a little bit lower." So then nominally it looks like you get like all of that health insurance covered, right? But like in fact, it's like from an employer side, it's like we're just paying it through like lower wages. So it's why I think it's a little bit tricky to look at that some sort of these splits and determine whether that's like how it actually parse out for people.
Thank you, Stefan. Laura?
Thanks. Just from a process perspective, I'm just trying to understand, do we need to select one or a set of these to, or like, are we just sort of thinking about these are measures we could potentially use? Or I'm just trying to understand exactly, yeah.
Yeah, we do need to come up with a definition of affordability and what we're going to adopt as that. Because I think those other groups are looking to align to make sure. And then, of course, whatever measure would come from that. And Sarah, do you have anything you want to add to that?
Yeah, and I mean, have to is maybe strong. I mean, I think where this conversation came from at last month's meeting was your question to yourselves about how will we know if a policy is improving affordability if we don't know what we mean by affordability. So I think the purpose of this and looking at the metrics would be to say, okay, when we think about affordability, these are three metrics, maybe one at each level, or these are
Okay.
two different lenses that we want to bring to the conversation. So I don't think it has to be, Jennifer, please, if you want to be a little more hardline on this, like your prerogative, absolutely. But I think it's not that there has to be like one metric to rule them all and that's going to be the end. I think it's more, do you have a shared understanding? Does that actually help you in reviewing policy?
Okay. Thank you. That's very helpful. Because I mean, a lot of these are great for different reasons. And I was like, are we zeroing in on only a few? And maybe Bill wants to chime in on that. So
Yeah.
thank you.
Bill, do you want to add to that?
Well, I'll just add from the board's perspective, I don't think we are expecting that you only got to pick one measure or perhaps one measure for each of the three groups. And it would be okay if you came up with a set of measures. In general, I think since this is a complex issue, there's probably not one measure that captures everything we want. And in fact, focusing on one measure can sometimes lead to unintended consequences that make something else worse. So looking at it from multiple perspectives, maybe not 10 measures, but a concise set of measures that addresses the focus on consumers and patients, employers, and the state, with one or more measures in each of those, I think would be just fine from the board's perspective.
Thank you. Kim.
Yeah, I was just, Stefan mentioned basic principles of economics, and it made me think about the 10% of income and how our health insurance works. If it's 200 bucks a month for you, it's the same 200 bucks whether you make 50,000 or 100,000. And so the percentages aren't, at least in my case, not a great indicator of affordability.
Yeah, when I was over a decade ago when I worked at UCLA, there was actually a leveling. So depending on your salary, they either paid, if you're at a certain threshold or below, they paid all of your cost of health insurance. And if you went between these two levels, they paid a certain percentage. And then the highest income earners, you had to pay the higher part of it. So they had broke it down off of wages to help rectify the low wage earners and not having to burden them with the cost of healthcare. So I thought that was the only time in my life I've ever experienced that type of model from a healthcare insurance from a private payer and a person perspective. So
and for the measure that we shared, typically I believe states use median income. So it is looking at an average, and yeah, it's not going to be totally reflective, but taking median does help address some of the maybe very high income earners that might be swaying that in one direction.
So thank you, Sarah. We've got like half an hour on this topic. And one of the things I think about is, the people that we represent for the whole state. In a couple of years, if someone looked at it, did we serve everyone well with the definition and the measures that we picked? And where do we want to be in a couple of years? And will we make real change and real impact with whatever it is that we choose, and moving this forward? It's just it's just very slightly short of world peace, but I know we can do this. Kelsey.
Yeah, hi. Okay, sorry, I was like trying to figure out how to raise my hand. One thing that I am thinking about is really centering and recognizing that it is important to like understand the experience of consumers, employers, and the state. And ultimately, with just how healthcare spending happens, the burden of the cost to employers or to the state will ultimately fall on the patient, like the person or the consumer experiencing that. So I think that I would really encourage us to not just in the kind of consumer and household lens as we're thinking about it, but also centering what is the experience of a consumer and how are we measuring that within the kind of employer and purchasers measure and also within the state measure too. And so I hesitate in those two measures to also just look at premiums because we know that premiums are not the amount that a person pays is only a tiny little piece of what the actual cost of their healthcare is out of pocket. And so I think that it's helpful to have maybe like a qualitative measure of do folks feel like they're able to afford their health insurance or whatever kind of qualitative measure that looks like. And then also more of a quantitative measure that can be trended over time. As we think about, Jennifer, to your question or to your question of how will we look back at this and know that we've made change in whatever that looks like. And so to the extent that we can be kind of centering that ultimate experience of like all of the dollars that we spend on healthcare at any level ultimately end up kind of as a affordability burden or a cost that everyday people are paying.
Thank you. That's great points. Linda.
And maybe building on that too, I guess I come back to something that's a little simpler and maybe too simple. But what about just reducing costs or unnecessary costs that just brings down the cost for everybody, regardless of who they are? So I understand that the challenge of affordability has to do with your ability to pay, right? But we don't have a system today that considers your ability to pay except for Medicaid. But in the world of employer paid insurance or in the marketplace, that doesn't really exist. So I think that's something, and maybe that kind of gets to what was it Laura who was just speaking was saying as well, is that if you look at everything ultimately ends up in the consumer's burden, whether it's a taxpayer's burden or whatever that is. So if we can get rid of unnecessary costs.
No, and to that point, there's a JAMA article that says between 25 and 30% of healthcare costs are unnecessary or waste. And so then that gets spread out across everybody, and everybody's contributing to that in some way or another, which is a lot of money. Patrick.
Yeah, I keep focusing on, and I'm just kind of building on the comment that was just made about the system rather than the individual pieces. And I wonder, is there something already known about like healthcare spend for the state versus like its GDP as compared to other states and national trends? And is that like a metric that we could use just to say, how does this affect overall the amount there is? That we're spending. And in terms of affordability, in my role, so I am a large self-insurance pool for cities and counties that are strapped in all kinds of ways and making really tough decisions. And the cost of premiums is going up a lot. And kind of the decisions they're making is, I can't afford this, so I'm going to pass it along to the employees, or I'm just not going to cover things. They're just not going to be paid. And so it's shifting things around. Like I feel like the decisions we make are shifting things around. And I guess kind of going back to, I hope in affordability we address like making it more affordable for all. I don't know. That's my dream. I don't know. Jennifer, you were very eloquent a little while ago, but
No, and I think exactly, Patrick, to that point, if we looked at waste, for instance, if we decrease the cost of by 30%, if we were magically able to decrease waste, all the waste, that would decrease the cost by 30%. And I would imagine that would have an impact on everybody because everyone's contributing to paying for that waste. And I don't know if I have never seen an Oregon report that says what does Oregon's waste look like compared to national waste.
I can jump in on a couple of points here, if I can, about what we have and don't have. So I think, Patrick, to your point about Oregon's healthcare spend compared to GDP and others, the group that I mentioned, the work group that's currently looking at that economic data, that's exactly what their conversation is going to be next week. And so as a follow-up, why don't we send this group the slides for that conversation, because you'll be able to see quite a bit of that data. And I think that is one of the reasons that other states have adopted as part of their definition or their lenses for affordability, looking at the overall total cost of care, growth in healthcare spending at that macro level. And then Jennifer, to the waste comment, it's not the full waste definition in that JAMA article. That's the 25 to 30%. But a few years ago, Oregon did do a report on low value care and look to see how much low value care there might be, and which markets and where there are opportunities. And I'm happy to share that link if that's of interest.
Oh, that would be fantastic. Thank you. I think I would find that interesting. Kelsey.
Yeah, I'm wondering, Sarah, I appreciate the point that you just made of the cross growth target work group talking about the kind of how spending is pacing with other kind of economic indicators, because that does feel like a both like many other states use that lens, and also like researchers use that lens oftentimes when you're comparing the cost growth to like other economic indicators like inflation and wages. So that feels like a helpful thing to look at, especially for the state spending, and maybe even also could be used for employers too, or you think about how much of an, I don't know if an employer something there around like economic indicators feels like that could also measure employers. And then it feels like for consumers, what would be helpful too is like measuring just the ability for like families to pay for healthcare in relation to all of their other costs. That feels kind of at the most basic level what is most representative of not just the numbers point to like this conversation of what we're talking about of like if you only make $10,000 or if you're making like $100,000 versus $50,000, $200 is a different burden on you. And so how are we capturing that experience in line with kind of our definition of affordability feels important of like what is the everyday experience of the person who is actually paying costs and not just like the numbers side of that too. So I would encourage us to be thinking about the kind of like how do we capture how folks experience healthcare costs too.
Laura.
Yeah, I would say on that point, just to echo what Kelsey said, that I really think those measures, the self-reported measures to Sarah's earlier point, are really important too, just because I think if you feel like your healthcare is too expensive and if you feel like you're needing to skip medication and skip needed care, that is important to understanding the experience of being a consumer, in addition to another metric that tells us more about like X% of, household income is spent on healthcare or whatever. That doesn't really, I like something that actually speaks to the consumer voice and how they feel about how expensive things are. I think that's important, but I agree it can be a little messier and it's subjective, but I do think it's kind of important too. So.
Because if we have a chance to change something, like this would be where we start. I had some initial, now that I'm thinking about this, I have some initial thoughts. I'm going to post in the chat about some definitions and metrics for consumers. And then sometimes it's really helpful. And I don't think we could do it on Zoom, but like notes and stuff to help think about and continue to kind of add and post things. So just some initial thoughts. And it comes from my perspective of we spend too much money. We're about to bankrupt the United States. And we got to do things differently. So we all have to do something different. So Linda.
Well, what I'm hearing, I think, is kind of back to what was it Bill was talking about. We're not going to do just one measure. So maybe what we do want to do is in order to avoid kind of those unintended consequences of focusing too much on one aspect, is look at one measure that measures the people's experience of what they're actually doing, how that's affecting them. Another that's just straight cost related, whatever you compare that to, compare it to other states or compare it to, whatever. And then the last one being some sort of more of a percentage of, how many people pay more than X percentage of their income. Those are kind of like what I'm hearing is some thoughts along all three of those, and maybe those are sort of where we start to get enough information to look at a pretty big picture without trying to boil the ocean.
Absolutely.
Can I ask the group a process question? But
Yeah.
Laura, please go first.
Sorry. No, I was just thinking about if I was going to ask if you could go back to those. I feel like you provided, was it 3 other states that have kind of a composite measure? Massachusetts, Connecticut, can't remember entirely. But does the agency have thoughts on what, what we already have access to? Like, I know our data might not be exactly what they have, but like, would we have the kind of data to put together a composite kind of measure like these for Oregon?
Maybe. We have a lot
Okay.
of this data, and I think maybe let me kick that back to you and say, like, what do you mean by composite? Like a single weighted indicator, like the Connecticut index, like
Yeah.
pretty big analytic lift. And
Okay. So
I have a
no.
lot of soapboxes about an index and how that masks everything, all the component parts of the index, and is that
Okay.
actually valuable? That said, we probably have a lot of the underlying data. And this is maybe my process question, actually. So,
Okay.
I mean, because what I'm hearing pretty consistently from everybody is value in having multiple measures that look at different lenses to this experience. And so I guess I'm asking, do you want to keep going and actually pick measures? Because then we could go with Jennifer's suggestion. We could set up some whiteboarding or do some like shared editing on a document and actually land measures. Or if the goal of this exercise and this conversation was to make sure you had a shared understanding of lenses, do you feel like you have that and can now take this conversation forward into reviewing policy? And we'll just keep reporting on all the data that we can report on. We can bring that to you. We have a report that my team puts out pretty regularly every year, impacts of healthcare costs on people in Oregon, that compiles a lot of these different measures. So like the data are available. Do you want to keep going down the path of saying like these are the 3 that we want to see every quarter? I mean, the data aren't that frequent, but on that we want to report back on, or is it enough that you have these as these are our lenses, these are the questions we're going to ask? Will this policy move the dial from an employer perspective? Will it move the dial from a I feel like I can't afford care perspective? And that might be all you need at this point. But that's my process question. What do you think you need?
I mean, personally, for me, over a period of time, I'd like to actually see that we have something specific for us in Oregon and be able to say, I contributed to a difference for the public in some way, or at least got it trending in the right direction. As people are counted, to me, people don't know this committee exists, but I think they have a vested interest in the success of the committee in helping them in their everyday life. And so to me, I think maybe a whiteboard or some work for us to continue. We can continue with our other conversations today, but some worked from my perspective on us maybe coming on consensus of when we're reviewing policies, will it help us get to the metrics we think are important for those in Oregon? And I'd love to hear from everybody else.
As far as data goes, from you, Sarah, at what point will we have information about potential healthcare increases in 2026 and like how that might impact, anything we say here? It's like, we might come to the conclusion that nothing's affordable. the end, you know? So how does, there's a metric and then there's the consequences and what happens afterwards.
Yeah, I think this is a trick question because there's a lot of different ways to answer it. I mean, we could say if we want to look at premium increases, the 2026 premiums are out there. We know what they're going to be. They've been approved. We can look at those and we can see how much they've grown. If we want to look at how much we've actually spent, it'll be a couple years lag before we have that data and can report back on, and here's what the actuals were. So do we focus on the premiums? Do we focus on the actuals? Do we focus on something else? For the most part, most of the data lags a year or two, but premiums we can look at um, earliest. And Stefan, others, TK, I know you're on if you want to chime in on this question as well.
Yeah, I mean, I think there are ways to get to a similar breakout or scorecard, and I do think it's very much worth it in terms of trying to, decide what the right moves forward are. But there are, there is a chance, as you mentioned, that, all of the options are very expensive or cost prohibitive in some ways. But I think even just surfacing it and coming out with something that would align with what Massachusetts or Connecticut have done would be a valuable endeavor. And just putting together that level of information for this group, my 2 cents.
Thank you. Kelsey?
I actually maybe have a point of disagreement here because of like 2 points. I would say the first is I would caution the committee against measuring the success of the policies that we are looking at against these very large indicators of affordability because we will not be I mean, as I heard last month, we are not going to be hitting every single piece of the healthcare puzzle that impacts a person's affordability. There's no possible way for us to do that with our picking two policies and then picking two policies and picking two policies. So I think that I think we'll be hard pressed to determine the one or even a set of 5 metrics that show, oh, affordability is better for folks outside of just experience. And then also to the point that was made around just the lag in data, realistically, theoretically, most of us will not be serving on this committee when we'll actually have the data available to know whether or not there was an impact made on that. And so it feels like this exercise is more helpful to use maybe in our matrix conversation of landing on how are we measuring up the impact or what policy approaches we want to be moving towards and have that kind of unified understanding of we will look at the data related to folks delaying or skipping care and measuring it up against that. Does this change the needle in helping people not delay or skip care? Or does this help to ensure that healthcare spending is slowed to a rate that is more in line with that, whatever economic indicator or whatever that looks like? Feels like it's more of a helpful exercise there. Because TK, I hear you on the would it be great for Oregon to create an affordability standard? Absolutely. And I don't I think that's a policy that we would do under our policy areas type thing versus us identifying, oh, this is how we're going to measure affordability in Oregon. That feels like 2 different things based on just the charge of this committee and where we are now.
Thank you. Stefan?
Yeah, I think if I track this correctly, I think you distinguish between measuring affordability and what we do in order to achieve better affordability. And I agree with that. I do feel like it's important to measure and to pick some. I guess that's maybe just my discipline speaking. I like the Massachusetts one because it's a global measure that can be calculated. I think it captures the total cost and reports it relative to the income. It seems meaningful to me. I would, and we would align it with Massachusetts. I would also argue that it would be helpful to, so I don't know how they define middle class, but I would stratify this by different levels of income. Um, and what to Sarah's point, like I think median is I think important, right? Because with a very skewed income distribution, you get a really wrong picture. Um, because people on a high income level will have much lower percentages, and that's really skews that affordability measure. I think as reporting it, like I think like one global measure and then like some breakout of this, I think would be really helpful. I would be really curious as a researcher to understand like which population group where across the like income or compensation spectrum has higher out-of-pocket costs. Like my take is that it's actually better for like people in the lower income who are on Medicaid, and then it goes up again, it goes up and then it goes down again. There's some sort of like it might be some sort of an important to understand that exact distribution. Um, I think I would also think for a dynamic perspective to look at the growth in income, right? So that because that's going to determine this measure, right? So we're related. And I think like it would be helpful to have a survey-based one as well. I think that would be sensible. I do think they are correlated, but I think it would be still interesting. So that's kind of like I guess my ideal set of measures.
Can I maybe make another proposal? So listening to this, this is actually really helpful, and it's making me think, what if a lot of this conversation we took back and informed OHA's next year's impact of healthcare costs on people in Oregon report? What you're saying is these are the things we'd want to see. Maybe here's like the cover page that's a little bit more of a scorecard on these measures. I think that fits with some of our intention to continue to compile this data and publish it. And maybe this is a repackaging. To TK's point about we have some of this, maybe it's more just putting it together in one place and making sure it's a little more digestible rather than saying you as a committee have to pick just two of these. And then next year, when we publish next year's report, you'll be able to reference back to that. And have it maybe packaged a little differently in line with this conversation and these priorities.
I think that is helpful. And it starts to get data for future, because this will be an ongoing, very long process for years. I think that'll help give future groups some of the information that they need to continue to make decisions and direction. So that would be very good. I would add, when we're talking about, of course, different states and states' affordability. Is there a reason why or why not we might not also look at other countries and high quality countries, high income countries, and look at some of the affordability metrics of those as well?
I could just
Does anyone want to weigh in on that?
Yeah. So it's a really interesting research topic. It's very hard to compare countries and their kind of costs because there's a lot of complications in doing that. There's some good research on that. I can share one or two articles that are fairly recent. They can make some comparisons in terms of that. I don't know if there's like on top of my head a definition of affordability. Um, I can check. I saw, I'm German citizen. I could see where I can find that information from some German colleagues or in France. What I will say, and this goes to the policy thing, I think my high level conclusion of that literature is that the states that have lower healthcare costs all did very clear and stringent measures to control it. And I feel like we are kind of like we are approaching it from our side, right? So we are like, okay, let's measure this, right? When we call it, what did the messages? That's actually the other thing I forgot to say here is like, so then if it's high burden or like we make a scorecard or we call it like unaffordable, right? But it's like what follows from that, right? That's a big question. It's like, Um, and I think that's the crucial one in terms of like what you do with that. And in a lot of these countries, when you look at them, it boils down to budgeting or putting a cap on prices and that. So like for instance in Germany, essentially like most of healthcare is public, and we essentially have like it's part of a budget process, right? So they define it top down at the federal level how much actually spending will be on healthcare, which seems totally, I think, bizarre from a US perspective. But then it's like that's your budget, right? So anyways, a lot more to say about it, but I can, as I said, could share one or two articles to get that started.
Nope, absolutely. Thank you. That data would be helpful. We have 4 more minutes on this topic. What else? Do we have a plan? It sounds like, Sarah, if you've been taking notes.
Yeah, here's here's what I heard.
Okay.
What I heard was that OHA will take this conversation back into informing maybe next year's impacts of healthcare costs on people of Oregon, a people in Oregon report, and maybe taking more of a scorecard dashboard style approach to that. Two, I heard that there's maybe still some interest in having a shared document and continuing to think about some specific metrics amongst you all, which we can facilitate as a follow-up that can inform both your ongoing conversations as well as our impacts report conversation. And then third, the interest that I heard from you all about multiple questions, multiple lenses, multiple measures, maybe is going to roll into our conversation for after the break about what are the criteria, what's the decision matrix. And so I did not hear an adoption of a measure or measures as an action yet, but I heard those 3 separate places the conversation is going to go. Does that sound right?
Does anyone disagree with that? Or is there anything to add to what Sarah has recapped? Laura.
I think just what I'm also hearing is that we're all in agreement that those 3 areas are the right areas and that that is how we will move forward. Is that accurate? I just want to make sure I think we've all
Sorry, the
agreed
3
that.
areas, meaning my 3 action steps or the consumer, employer, state is the 3?
The latter.
Okay.
And then did we want to, on a future meeting, use whiteboard and talk about and kind of help with the information we get, look towards some type of definition or some type of generic metric or some type of thing that maybe it's not a metric as much as it's also a guiding principle for us to say, when we're looking at stuff, these are the 3 things that we want to make sure we're looking at something from the lens of.
I like the idea. Oh, sorry, I did not raise my hand. I like the idea of a kind of a guiding principle, like as we think about creating what is our decision-making matrix, I think it is helpful to have a guiding principle, sure. That's a good way to call it, to just kind of help narrow in what are the questions we're asking ourselves then when we're looking at impact, etc.
Thank you. Anyone else want to talk or add anything? Nope. Okay. Well, thank you for that, the interaction and the questions and comments. That was very good. I do believe we have a break right now for 5 minutes. So everyone gets a 5-minute break and we'll come back. Okay? I'll see you in 5 minutes.
Right, it's 3.
Okay. So next on our agenda is for us to look at, for the next 30 minutes, criteria for developing policy recommendations. So key questions to ask about potential policies and discussion and decision, adopt questions, matrix, or processes for reviewing policies. So, Sarah.
Yep, I'm going to talk us through some more slides.
Thank you.
So next slide, please. Just a quick reminder that the purpose of the Affordability Committee is to develop and recommend cost reduction and cost growth reduction policies and initiatives. So that's the end game here. Next slide. At the kickoff meeting in September, when you all were starting to talk about the affordability policies document and the proposed work plan, which said, let's pick some policy areas and dig right in. You said, well, wait, we maybe should think about a decision matrix or some key questions that we can agree on up front that will help review or vet the policy ideas. And a couple of quotes that we pulled out of the notes from you. What questions do we need answered to feel comfortable recommending a policy? And how does each policy further the committee's objective? Next slide. So as Bill mentioned at the top of the meeting, the policy board is interested in pursuing guiding principles to support the Affordability Committee's work. And Bill and Tony and the board are working on that. And I think the plan is to bring that back to you for the November 25th meeting. Bill, Tony, I don't know if you want to say anything else about additional guidance right now. Okay, seeing none. So I think what we want to do is present you with some options and an example of a framework that Washington State used when they went through this process and prioritized their questions last year. So I'm going to just give a little bit of background on that. And then we're going to give you a starter list of prompt questions and then have you open it up for discussion. And is this what you had in mind? Do these resonate? What other questions, what other criteria would you like to adopt? And I want to preface this with, again, I think this is the format, the style, what you land on is very up to you. And the question here is what's going to be the most helpful tool for you in doing your work. If you want a matrix and a list of questions, if you just want a list of questions, you want something else entirely, I think that's all okay. I don't think there's a preferred format coming out of this conversation that we're hoping to land on. So next slide, let's talk about what happened in Washington. And I think Laura, you mentioned this, or maybe Kelsey at the last meeting as a good example, and we agree. So here's what happened in Washington. Washington's Healthcare Cost Transparency Board is charged with providing policy recommendations to their state legislature. They have some other charges, but this is the one we're focusing on specifically. They submitted a legislative report late last year, and had policy recommendations, including facility fees, oversight of healthcare markets, increasing spending on primary care, and exploring a reference-based pricing model. So in getting to those recommendations, they went through a policy prioritization and some decision criteria processing, and they sorted their potential policy ideas by who was working on them, what level of impact the policy might have, and whether or not it was a short, medium, or long-term policy idea. So next slide. We have two graphics pulled from Washington's report and materials about how they did this. And so they had a list of policy ideas, and this is how they started sorting them against those criteria. So the two columns, policies that someone else was addressing. Someone else in the state was already working on it. There was already maybe legislative movement. There was already a state agency moving a program forward, something like that. So somebody was already making progress on something. And then there were things that nobody was working on. And those are in the boxes on the right. In the rows, they thought about who the policies affected. So things in that top row, they may have an impact, but they're not specifically targeted on costs from maybe a consumer perspective. So things like administrative simplification might really improve costs and some of those waste issues in the system, but maybe not necessarily resulting in an immediate savings or feeling like healthcare is more affordable from a consumer perspective. In the middle, they focused the green box and the green row are consumer and purchaser cost protection policies. The purple box are transparency tools. The dark blue box are policies that directly address high costs. And then the last row are things that have enhanced regulatory authority. They further sorted this by high, medium, and low impact. That's the red, yellow, green circles next to each policy idea. And by short, medium, and long term. And that's the numbers next to each policy idea. So there's a lot going on in this chart, but this did give them a snapshot of what they were considering and who it might affect and who was working on it.
Real quickly, with like the not being addressed, what did they do with that section? Was that where the recommendations were kind of geared down towards?
I believe so. We can confirm, but I think they ended up focusing, and the things that made it into the recommendation came primarily from that list.
Okay,
Nobody else was working on it, so we should advance it.
okay, thank you. Linda.
Um, yeah, I'm wondering, did they have these ideas and then categorize and then group them and figure out categories? Or did they do it the other way around? Did they have categories and then think of things to put in the
I
categories?
think they came up with the ideas and then categorized them, but I'm not 100% sure. Kelsey,
Okay.
Laura, do either of you know for sure?
Yes.
I mean, I really like this method. This works really well for me personally, to start to see, just to throw out ideas and then start to see where they land. I just think that's a really good way to get moving.
From my understanding of how Washington approached this, the policies that they considered in here were put together by their healthcare authority, their division of insurance, as well as a couple other kind of state agencies weighing in, the governor's office, legislators who had. So these are all policies that have either been presented to Washington's Healthcare Cost Transparency Board, or the Division of Insurance had considered previously, or were just things that the state was like, wonder if we should take these on, kind of.
Thanks, Kelsey. Okay, next slide. So in addition to this way to look at their list of policies, they also put them on a matrix to look at complexity and cost. So on this slide, things near the top of the chart have higher complexity, and things near the right of the chart are more likely to have a greater impact on cost. And so this let them sort of create what are we going to get for our effort? How much will things move the dial versus how much work we have to, or resources we have to put in towards them. And my understanding, again, of these conversations that I was not in was that they use these sort of in parallel to help narrow down what their recommendation should be.
Did they have a time frame on the impact? Was this like 3 to 5 years? Was this 10 to 15 years? Did they like,
I don't know that off the top of my head.
okay,
It might be in their report and we can look.
okay, no problem. This still feels very sick care based, so.
All right. So with that as an example of how one state has sort of ranked and grouped policies, let's talk about some potential questions that you all could adopt and some potential matrices that you could adopt. So next slide. Here is a list of potential questions that are informed in part by your initial conversation in September, as well as some of the charge in your charter. So one, does the policy move the needle on the committee's adopted definition or measures of affordability? So I think this is the conversation we just had. Would it have an effect on consumers? Would it have an effect on employers and purchasers? What would the effect be on the state? Does the policy challenge the status quo, part of the committee's charter? How long would it take for this policy to be implemented or to make a difference? Is there evidence supporting the policy? Who would be affected by the policy and who would be left out? If the committee doesn't recommend this policy, will this work happen elsewhere? So this is, is somebody else working on this already? Does the policy have the potential to result in shifting costs elsewhere? And are there other potential unintended consequences of the policy?
One thing when I look at this too, and maybe it's the overall guiding principle for all the questions, is does it improve the health? Because if we improve affordability, but it doesn't make a difference in someone's health, improving health, are we just looking at the affordability of it, or is it really both in the essence of it? We're improving someone's health, and we're improving affordability. Because if we improve affordability, but it actually is negative impacting on their health, is that okay?
I might ask again, Bill and Tony, if they have perspectives from the board on that question. Again, thinking specifically, like clearly if there's a connection, it's related, right? And so, and you look at some of the policies that are on the list, like we should invest more in primary care. And so does that do both, improve affordability maybe and improve health? But then there are other things that might only be one or the other. And I would look to Bill and Tony, and maybe this can be part of the guiding principles conversation if the board wants to give more direction here.
Mhm.
I'll give an initial response, but I think this is an important and complex topic without a simple answer. I think ideally the board would love to hear recommendations from this group of things that improved affordability and at the same time improved equity, quality, and access to care. However, I think there are also some things that would and could improve affordability while at least maintaining or not harming
Not harming.
quality, equity, and access to care. So um, there's an ideal set of things, but I think there may be some things also that are just about affordability, as long as it maintains. What we do not want to have are things that we think there's a significant potential for harming, maybe improve affordability, but harms quality, equity, or access to care. I don't know if Tony's on, but I think he may have something to add, or hopefully he would have some thoughts on this as well. He might not be on the call, though I know he's seeing patients this afternoon.
Oh, thanks, Bill. Yeah, I'll jump in. And I haven't been entirely here for the duration of the conversation. So just to put that caveat out there. And I agree with you, Bill. And I think you summarized it very well. I think in that space of do no harm, but try to improve access and healthcare outcomes, right? And I think that it is, again, a difficult question. What we're facing and the charge here is lofty. But I think that approach that Bill outlined summarizes it very well.
I like that as a guiding principle, do no harm. Kelsey and then Stefan.
I was just gonna, I guess Tony and Bill mentioned some of this too, but Jennifer, I do think that I would like to see captured in some of the potential questions that we're weighing, some of those other things like how does this impact or how does this weigh against the health outcomes, the health equity pieces, and overall access. But I do think that the affordability is like the overall, how does this improve affordability is like our overall charge. And then those are considerations that we're making as a part of, is this improving affordability while also X, Y, and Z kind of thing.
Another system for the matrix we can add on to it. Improving or doing no harm. We need a 3D model for the matrix. Stefan?
Yeah, I want to I think it's an important point. There's like, that's called the iron triangle of healthcare, right? That you have cost, access, and quality, and you can improve one, but not all three at the same time. It's kind of like a long-standing, some sort of mantra. I would make a pledge to keep being focused on affordability. I think this is the affordability committee, and there are other topics that other committees are tackling. I also want to say it's like, it's like, I think you mentioned like with some sort of like the 20% part, right? So that means like health is affected by many factors, and I think there's some sort of like there can be trade-offs between cost or like health and healthcare. But there's just like so much more beyond the healthcare system that affects health. So it's hard to kind of, in some ways it gives you a little bit leeway, right? Because it says like, let's just focus on our affordability, and then there is like these other dimensions we need to focus on.
Thank you very much. I do think it's like still kind of the overarching piece that we should always think about too, because affordability, we could just say we're going to stop paying for all surgeries. and then decrease the cost, but that's going to be bad. So that, I mean, that would be the extreme case, right? Is like, we could really slash and burn from an affordability perspective, but that would not be the intent. We want to make sure people get the healthcare that they get or that they need, that makes them healthy, or does
Yeah,
not
the
alter.
risk of that perspective is that you move forward with something that is not then really moving the needle on affordability, because you always have these trade-offs and you always have to work with them,
Mhm.
right? It's like so then you have to kind of, in some ways you have to pick and choose a little bit, because it's so easy. You get a lot of pushback
Mhm.
when you put something forward, and it's so easy
Mhm.
to then go with something that has lower, like relative low impact. So I think there is a little bit of, I think we have to have like a little bit of a decision process about like what do we, what do we want to prioritize and focus on. With a total agreement with what you're saying.
Oh, no, absolutely. And that makes me think about some of those metrics, Sarah, like in Oregon,
Yeah, let's go to the next slide. Perfect.
so, and I'll just finish this one. And it's kind of like, for like the future, even collecting data, like what percent of Oregon is spending money on public health, right? Because that's part of, what percent is primary care? What percent is ER? What percent is surgical? And then what's the cost trajectory of each one of those, and what's the cost been over, and I don't even know if we have that type of data that says, here's what we've been spending, and this is growing, this bucket is growing much more substantial than another bucket. And there's probably 1,000 reasons for that. But I think from an affordability perspective too, that helps us to understand where these major buckets are and what that growth looks like in some of it when we're trying to make some recommendations.
Yeah, no, we do have a lot of that data. And I'm wondering if this actually maybe would be a really good, um, maybe the November conversation, November agenda should be shaped around looking at some of that data and understanding what the key cost drivers and projected drivers are, because then we'll have had a conversation about what is affordability, what are some key questions that we care about, what are the drivers, and then we can come back to that list of policies and say, okay, we want to focus on policies that would address this particular cost driver or this particular part of the system. And that feels like a pretty good
Mhm.
arc of the conversation. So maybe today we finish
Yeah.
brainstorming some, not finish, but continue brainstorming criteria and key questions to ask. We structure the November agenda around
Mhm.
the data and what we know about what's actually driving costs right now
Yeah.
and where the money is going. And then come back to the list of policies.
Thank you. Ooh, get a
Okay.
decision matrix.
Yeah, so we can create any kind of matrix for Oregon. I think depending on what criteria you want to put on, we could definitely look at the short and long term. We could look at the complexity. We could look at the cost. Um, Next slide. But again, this is like agnostic. So do you want a matrix? Do you just want to have a list of questions at this point and we come back to this in future meetings? Um, do we want to continue developing out some guiding principles that maybe are the same as the questions or have a Venn overlap with the questions? Like what would you want to leave here today
Mhm.
having?
Great question, Stefan.
Yeah, so I'm curious why we picked complexity here as the other dimension. And I think one thing we could do is, I think it would be helpful um, to to understand that better, maybe at the next meeting or between the meetings. So if you develop some sort of like a similar matrix, I think we could do. It might be interesting to do the matrix by access and costs, right?
Mhm.
So that would be an interesting exercise. But I'm curious why they picked complexity and how
And
it affects that. Yeah.
I will clarify, nobody picked that. I just threw that on the slide for discussion. So I think if you want to agree that complexity is not the right,
No, the Washington one.
yeah, why they picked it.
Yeah.
I mean, I think my understanding of the Washington process, and again, Kelsey helped me because I know you tracked that conversation, was twofold, that they were looking at both the resource lift that it would need, like would there need to be a legislative investment of funds and a program to actually implement the policy and make it happen? And then how hard would it be for the industry to implement?
Mhm.
And they were looking at both of those things under complexity.
Mhm.
So it's a bit about like feasibility or
Yeah.
like the process, the political process involved in it. Okay, got it. Yeah, that makes sense. Yeah.
I think so. Kelsey, is that?
I would also add that Washington, in putting together this matrix, contracted with an organization to help them do that. And so this was also a suggestion from the consultants that they, from my understanding, was the looking at complexity, impact timeline, all of these things were recommended by the consulting firm that Washington was using here as well to like start this conversation.
Thank you. Kim, I saw your hand up.
Yeah, I guess for what it's worth, I wanted to add that seeing those slides from the Washington information or data was a little bit hard to read and comprehend on a, I don't know if that's what we were just talking about, but quickly. It's hard to do that quickly and understand what you're getting out of it. So if we're looking at people understanding what we're doing, that wasn't easily understandable very quickly.
Thank you. Would you like to go back to those slides or?
No, I don't think so. It's just
Okay, for future. Okay, thank you. Let's see, Patrick and then Stefan.
I wanted to say that I know that we're developing ways that we're gonna pick what we're gonna work on.
Mhm.
And I think that I really hope, like kind of starting with our affordability discussion and those different measures, what we don't have and we haven't received is any sort of measures of Oregon or what we're tackling. And that's some perspective that I would really like. And I think I really strongly agree from our first meeting that of all these many, many things to work on, that picking a few that could be impactful is something I would advocate for. And so I think one of the questions is, or two of the questions, one is how impactful would it be? Like how, does it tackle one of the areas where we really need something, or does it have a great impact? And the other one is, I really liked at the very beginning the three different charges we had. And I think an initiative that tackles all of those, if there is such a thing, would be something I would advocate for in picking.
Great, thank you. Stefan.
Yeah, two questions. One thing is, I think if you do something similar, I think it would really help me to understand what the labeling is on the X and Y X. Sorry, I'm getting technical here, but so sorry, speaking up. So it's like, when you look at that some sort of impact thing, does that mean like, if you move from this one to this one here, it's like a minuscule change, or is it actually a really big change, right? In like what metric, right? So I think that's important, right? Because if there's a huge change there in terms of like how it affects affordability, I think I would gravitate more to the ones that have more complexity involved. I think the complexity is probably harder to measure in some ways, or like quantify. If a range is pretty minuscule, I would just go with something that's like more feasible. So I think understanding what that range looks like would be really helpful. And then another thing, what I was wondering about this, just throwing this out there, is like, I think like all of these are operating within our current system. I don't know if there's any appetite of like thinking outside of that box. But I'm also wondering about like how much can that really like how would that look like within our current system? So both things, I guess, was two different questions. So what I mean with that is, for instance, if you do like a price computation, do you have authority to do it on the Medicare side? You can do it on the Medicaid side. Do you have authority to do it on the Medicare side? I don't know. I think you have authority to do it on the commercial side. Not fully sure. And then, and like I think related to that is some sort of like other perhaps bigger changes. Universal healthcare would be one of them that is like not included in this metrics.
I think if we're looking at affordability, then we need to put anything on the table that needs to be there, and see how far it floats down. Kelsey?
Couple of things I would consider on the affordability piece, and also just maybe thinking about where our recommendations go to the states. So like Oregon I mean most policies only has authority if we're thinking about like insure in markets, generally speaking, only have authority over commercially insured markets that are like the state employee health plan, individually insured, the individual market, so folks accessing coverage on the marketplace, and small group market as well. So large group or our plans are covered by ERISA, which is a federal policy. And also Medicaid on the like public payers, Medicaid, the bridge plan, I guess, technically. On the market side and to the Medicare point, do not have, cannot make Medicare policy, but can for Medicare Advantage plans. And so I think when we think about impact to that, like even just to like that very simplified point there, I think it's fair to say like how many, like quite literally how many people will, like how many Oregonians will be impacted by this policy. And weighing that with the access that goes along with that. So maybe there's only like, I don't remember off the top of my head how many, 130,000 people access like coverage on the marketplace in Oregon. And so relatively small-ish population, but massive impact for that like market of people. And so I think that when measuring impact, it's helpful not to just look at the number of people impacted, but also like what does that mean? What does that change for that population also look like to the points that we're talking about of equity and access and outcomes, et cetera, et cetera.
Thank you. We have 2 minutes before public comment. I don't know if anyone's going to join us, but Bill.
Just a quick comment following up to Stefan's question, and I think Jennifer, you commented on this too. I think from the board's perspective, we would not want you all to feel constrained to quote work within the current system as is, because the current system isn't working very well for most people, and also because the size of the problem of the affordability crisis and requires, I think, some bold steps. Now, I also would caution, don't try to come up with a universal health care plan that's, that would be probably too much. But I believe there are steps that may require legislative changes in the state's authority. That could be a change from the current system. So, and there may be a combination of short-term, immediately, more easily achievable, less complex, less difficult steps to do, but also we're looking for longer term, more impactful, more systemic changes. So now, if I figure out exactly where the boundaries of that is to be determined. But I would say, using a baseball metaphor, since it's World Series time, I wouldn't don't try to stick with bunts and singles. Look for some extra base hits and maybe even some home runs.
Thank you. That's perfect for World Series time. So thank you very much for that. We are at the time for public comment, and Sarah, I'm gonna hand that to you.
Okay, we do have one person here to provide verbal comment, and we have a second group who submitted written comment, which I will put the link in the chat momentarily. But Jennifer, are we okay? Can we just wrap up that conversation on
Yep,
where we
absolutely.
actually landed?
Yep, please go ahead, Sarah, and recap what you believe.
Well, I think I'm not sure what the recap is. I mean, I think I definitely heard some things that people want to add to the list of questions.
Yep.
And I think there was a lot of agreement and heads nodding, particularly around the impact,
Mhm.
and sort of ability of authority to implement or, adopt a policy. And so I think those are key to add to the list. Is it fair to say that the committee is comfortable with the list of questions and we may or may not put policies on a better defined matrix in the future, but in the short term, a working list of questions, you feel like maybe you have more of a grounding point
Mhm.
moving forward?
If everyone's in agreement, thumbs up on that one. Good. And I do think it would be helpful too in the next couple of weeks before our next meeting, if everyone provided maybe one suggestion towards a guiding principle that's near and dear to them. And we can consolidate and also look at those and have a conversation to continue that component of that. That would be helpful. And if Sarah could collect all of them.
Yes, please. We'll send a follow-up email with the requests and a prompt for that, and that would be great. Thank you.
Perfect. Thank you.
Okay, so public comment. First, oh, okay, looks like we have two folks for verbal comment. I'm gonna put the link to the written comment in the chat. So folks have that. And then Colin, I think you are first.
Hi, can you folks hear me okay?
Yes,
Okay,
Colin.
great. Thanks for giving me time to speak and giving me 3 whole minutes. I don't think I'll take that whole amount of time. I really appreciate all the work that you're doing, and it's great to listen in. I do feel like I'm learning a lot. I work with Healthcare for All Oregon as a contractor working on their communications, and I'm speaking to you, from Healthcare for All Oregon's perspective, but mostly just as a patient and as a patient advocate. And it's pretty alarming that you folks are gathered together discussing a desire to really leave a mark on healthcare affordability in Oregon, a desire to change the system that you all know is broken, and a total lack of discussion of the work of the Universal Health Plan Governance Board that will be delivering a transition plan to universal healthcare in 2026. I feel like, well, I don't really know, but I assume some of you on this call know exactly what I'm talking about, but I fear that some of you on this call dedicating your time, your energy to trying to make a plan for Oregon don't understand that in 2026, we're going to have a transition plan. In 2028, we're likely going to vote. And from my perspective, I don't know if you've heard about the healthcare system being broken. It seems likely Oregon's going to move towards a universal healthcare system with that vote. 2030 potential implementation, and 2032 maybe getting the final Medicare waiver for us to implement a Oregon universal healthcare plan. So that's coming right up. And I fear that you aren't engaging with that possibility in this conversation that you're having for the next several months about how to save cost. And you're going to kill us. As a patient, my life is in your hands, and it doesn't seem like you're acknowledging this reality, and it's really alarming. So I get emotional talking about it because I'm pretty afraid. Are you? Um, so yeah, I just encourage you to actually include this topic that you all know exists, or you should. If you don't know, then this group is doing you a disservice by not bringing it to the table. And yeah, we need universal health care. All of you know it. It's time to start acting like it. So thanks for your time.
Thank you, Colin, and thank you for bringing that to the forefront for us. And we'll make sure that we share that information to everyone to ensure that everyone's fully informed on the work of that group.
All right. And our second commenter today is Andrew.
Hello, thank you for this time. I want to thank OHA for the opportunity for public comment. My name is Andrew Kilbach. I'm an associate with OSPERG, a nonprofit public interest group. I'd like to request that more attention be given to facility fees as a pervasive cause of high healthcare costs. So facility fees, as I'm sure you all know, are fees charged by a hospital that owns other clinics. Although originally intended to be a way for hospital campuses to pay for their operating costs, over time they have warped into a loophole to charge off-campus patients unexpected and unfair bills. Now, facility fees are most often charged at off-campus hospital facilities for essentially walking in the door. Although facility fee data for Oregon isn't publicly available, we found in states like Colorado, facility fees are now most often charged on routine care far away from hospitals. For example, one type of facility fee charged over 500,000 times from 2017 to 2022 in Colorado was for an assessment and management visit or an off-campus check-in with a provider for 20 to 29 minutes. The average facility fee for that 20-minute check-in was around $70. Although for other procedures, facility fees can range from 50 to in the thousands of dollars. We found insurance policy towards facility fees is inconsistent, with many patients left to pay out of pocket. Worst of all, providers do not have to notify patients of this charge, meaning people have gone to the doctor expecting to receive a $25 copay and instead got a bill for over $100 that they couldn't have expected. Facility fees increase the cost of healthcare without improving the quality of the care. And although hospitals will argue that they're necessary, a closer analysis reveals that it is far from a vital revenue source. 73% of facility fees billed to Medicare patients in Colorado were from a single hospital system. And in other states that have published their data, we found similar results. Not every hospital system charges facility fees nearly as frequently because fundamentally they aren't necessary to maintain high quality care. The way facility fees are used is not acceptable, and people should be able to have access to high quality healthcare without unnecessary fees tacked on. So we urge you at OHA to take a closer look at restricting facility fees as a necessary step to reducing healthcare costs in Oregon. Thank you for your time.
Thank you, Andrew. Sarah, was there anything else?
Nobody else said they wanted to provide public comment in the chat. I guess last call. Is there anyone else here for public comment? Okay. Then Jennifer, I think we're ready to wrap up.
Thank you very much. So we have a plan moving forward for our next meeting. You'll expect, of course, notes and stuff from, and Sarah will be sending out, or someone will be sending out additional information in our preparation for our next meeting. And then I would also add, Sarah, if you can make, if we could provide any information that we may have on the committee that Colin had mentioned, just to make sure that everyone is aware, that would be wonderful. Does anyone else need or want anything or would like to add to that? And then, of course, sending your guiding principle, at least one guiding principle for the committee that would be helpful for us from a grounding perspective.
And I would also note the Industry Advisory Committee will be having their second meeting on November 17th. Their conversations are staggered off of your conversations, so they'll also be talking about affordability and decision criteria, most likely, and reflecting on some of the discussion you had. So if folks want that calendar invites or want to be tracking that conversation, that meeting is coming up before your next meeting later in November. And we can share that out if that would be helpful.
That would be, at least it would be helpful if we have time, if people could be, if they had time to follow in with that, that would be wonderful. Thank you. The more information, the merrier.
One quick question just on like process with the Industry Advisory Committee, which I think we talked about last month and I may have forgotten. Sarah, is there like a representative from the Industry Advisory Committee that will be attending these meetings, or is that you as OHA staff?
I think that is an open question. There's not a seat on the Affordability Committee, but it is part of the expectation for the chair and vice chair of both committees to attend and cross-pollinate when available or when needed. So I think in these early days, staff will probably just keep providing updates, but I think there will be some times where we ask the chair and vice chair to come to you, and we ask your chair and vice chair to go to them.
Got it. Thank you. I couldn't quite remember what we had talked.
Okay, is there anything else that anyone needs or any other comments about today's meeting? Closing thoughts? All right, Jennifer, last word. Otherwise, I think we're all set.
Thank you for everyone's wonderful participation, and for those who can be on camera during that time, I greatly appreciate it. So thank you, everyone, and we'll see you next time.